So hi there, I'm Kelly Mussi. I'm the Assistant Director of the Transitional Care Department, and I'm going to talk to you a little bit today about our high utilizing program. We refer to it at the hospital as HUP, but I'll tell you a little bit about HUP. HUP was a program that was created about 15 months ago, so a little bit before the intensive transitions team came into play, and we started doing the work that we're doing with the intensive transitions team. But the high utilization program was really born from us talking to the social workers, physicians, case managers, nurses, people in the ED who knew several of our patients on a first name basis. So we have a group of people that are utilizing our ED on a fairly regular basis. So we worked with our IT department to kind of build a list of the top 50 ED utilizers, so the people that are in our ED the most, and we decided to look at that group based on a 6-month period of time. And imagine the shock when we found that our top ED user in a 6-month period of time was there 112 times. So 112 times. Number 2 came in at 97. So all of a sudden we saw a group, and really when we were designing this program, we had to make some very broad criteria because of those top 50, 40 or more of them were in our ED more than 50 times in a 6-month period of time. So we decided, Mark and Diane had previously created a program very similar to this called the Frequently Admitted Program, but we decided to take a look at this group of people who was using our ED frequently and see if we could build some programs to support them. So the program addresses people that have been in our ED 5 or more times in 30 days or have had 2 hospital admissions. Now, a little bit different than the intensive transitions team, they're in our ED, but they're not staying. So maybe they're coming, but they're not necessarily admitted. So we have to kind of look at what is bringing people to our ED. One of the things that we identified was certainly lack of primary care. So people were coming to the emergency room to get their sore throat looked at, their rash looked at, their headache, things that you and I might traditionally go to a primary care appointment for. So that was one thing. So we added a patient navigator to our department, and that patient navigator works in our ED from 11 to 7 and interacts with people who lack primary care. And at that time in the emergency room, tries to identify a primary care that's available, whether it be in our own hospital system or at Syracuse Community Health Center or some of the other primary care offices in the community, and immediately sets them up with an appointment so that they will have access to primary care. So that's one of the things that's been very helpful. But then you have to look at the other reasons that people come to our emergency room. A lot of them, it's an inability to manage their chronic condition. So they have a primary care or they go to a clinic and they're given instructions, but because of literacy or cultural competency or a knowledge gap, they're unable to follow those instructions. So you give them an inhaler, you give them a medication, you send them home, and they really have no idea how to use it. Or they lack the resources to pick up the medication. We prescribe a medication, but we never ask if there's transportation or financial resources available to pick up that medication. So therefore, they don't get the antibiotic that they needed, and they return to our emergency room hoping that somebody will be able to help them. We also see people that come for addiction issues, whether that might be trauma because of their addiction issues or because they come seeking additional medication or opioids from our emergency room or something of that matter. And then we also see people who simply come for socialization. And for those of us that work in the hospital, I think it's very difficult to believe that anyone would want to come to our hospital to socialize. It's noisy, it's crazy, it's busy, there's a lot going on. You don't really get like great one-on-one attention in the emergency room, but yet we see people who come almost daily to our emergency room because it's a friendly face, it's somebody that knows them. So I think that's the area that we really need the support of this group from, is how do we engage those people somewhere else besides our emergency room? not only is it not the best place for them to receive their treatment, you also have to keep in mind that our emergency room is a level 1 trauma center, and we actually have people that need to be in our emergency room that could benefit from our services. And there are many times when we're unable to take transfers from other areas, or there's a wait on somebody who really needs to come from the North Country or from Utica because they really need our services, but we have 50 people waiting in our emergency room. So what we did was we decided to work with some of our community partners, Health Home. St. Joe's has a health home, and CertCare has a health home. And health home case managers really are the people out in the community who are helping people manage all these pieces in the community, helping people get the right housing, the right transportation, the right appointments, and trying to manage all of that for people who are unable to, for whatever reason, manage those pieces of their health care. So we decided to partner with one of those local health home agencies and embedded them right in our hospital. So there is somebody that sits at our hospital every single day, 5 days a week, that we can say, we think this person is appropriate for your services. This is different than home care. Home care, the traditional home care that I worked in, Terry, Diane, you were in, was, you're going out, you're teaching people how to use their take their medications, you change somebody's wound, you're checking their blood sugar. These are health home case managers. So they're really addressing a lot of behavioral issues and management of people's care. So we have someone that sits in our office where Diane and I sit every day, and our case managers, social workers, anybody that works at our hospital can call down and say, I think this person is appropriate for health home. They could benefit from case management services. It's designed primarily for Medicaid, but they do have space for Medicare patients as well. So we can get them hooked up right there at that time. Behind the scenes, we created a readmission flag. So every time one of these people that's a high utilizer comes to our ED, a little light goes off, or a little flag goes off in our medical record that says, hey, we have somebody that's a high utilizer here, and they send a social worker down to say what's going on, making sure that this person has access to the community resources. You were just here. What brought you back? What went wrong? Did you not fill your med? Did you not get transportation? Is there a housing issue? So tell me why you were just here and now you're back, so that we can try to figure out what the driver is of them using our emergency room. And then in addition to that, we meet monthly with the case managers in the community to discuss the progress. We're very lucky. Samadi, who you met up there, is our program coordinator. So she pulls the number of visits, and we kind of look with the case managers in the community. How often has Terry been here? What time of day is she coming? What's going on that brings her here? And we try to work collectively with one another to figure out what is bringing this person to our emergency room, and what else can we do to support them. Since we've been measuring data, and this actually is a couple months old, but when we look at our 1 year pre and post data with HUP active patients, we have seen in this program a 32.7, and I think it's a little bit higher now, reduction in the amount of ED visits with this group, simply from adding the patient navigator that's helping them get primary care and working more closely with that one community partnership to try to address the needs of these individuals. So I think from where I sit and from where our team sits, there's a lot more potential to make that number even greater if we had involvement from other people in the community. What else can we do as partners with all of you in this room to really help people and meet them where they're at? We try to ask people on a regular basis, but and I'll be honest with you, I think sometimes the ITT has a slightly, no offense, a slightly more, better advantage because they're in the hospital, so they're there for a little bit longer period of time. So we're trying to find out quickly with people, what gives your life meaning? How does your belief system influence your healthcare decisions? Are you part of a congregation or any spiritual group that we might be able to contact? Is there any one group of people that are important to you? And how can we, as providers, engage those people? Can we reach out to your church? Can we reach out to the fire department? Who knows you best that might be able to work with us? Because I think there's a lot of opportunity to engage other people in the community besides the paid workers, which I think at the hospital, and my team has heard me say this a lot, we tend to think when numbers increase or a problem is expanding that we need to add an additional paid person. How do we get another social worker? How do we get another case manager? And we forget how many people are in the community surrounding us that might be able to support some of these initiatives and provide peer engagement and support to them outside of our four walls. Unfortunately, one of the things that came out of beginning to collect this data and look at these people were some other issues that we identified. When I first started this program 15, 18 months ago, one of the highest number of individuals that we saw on our in our ER was sickle cell. People with sickle cell disease. Very, very small group of individuals that had very, very high utilization in our community. And there's a lot of studies and a lot of research that goes into that. Generally, they are young, black males, often unemployed because of the chronic disease that impacts them. They use high doses of narcotics and pain medicine to control their symptoms. So they're a group that unfortunately has a large label already attached to them, even though they're chronically ill. So when we looked at the original group of people that were using our ED, sickle cell was one of those groups. Through our partnership with Health Home and through better work through our cancer center and some really, really good case managers in our department, we were able to decrease some of those numbers, and we're working very closely with our cancer center to better meet the needs of those individuals. So it used to be that several of the top 50 ED users had sickle cell disease. When we ran the numbers this month, there's only 3 on the top 50 that have sickle cell disease. So that's a really, really great thing for us that internally we've been able to address those issues. Unfortunately, what has ramped up, and most of our top 50 ED users have, are addiction issues. We have a very, very large population in this county and in our hospital and all the surrounding counties that have addiction issues. So out of that, what we decided to do was really pull together a pain task force. And what we do is we meet once a month, and the pain task force is made up of a variety of people inside our hospital. So we're an internal group right now, but that's not to say that we certainly couldn't expand that. And it's made up of providers, addiction and pain service, social work, case management, legal. All different people come to the table to talk about individuals who are repeatedly in our emergency room or admitted to our hospital who are drug seeking or have addiction problems. So we have taken each one of those cases one by one, working with their primary care, their case managers in the community, family members, and developed individualized care plans so that when someone comes in, say Mark comes into the ED and he comes constantly complaining of chronic back pain, we have it set up so that the minute that you open our medical record, we say, when Mark comes complaining of chronic back pain, do this, 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 and this. So we've developed a way for doctors and other providers to not have to think about how to treat Mark. We know that Mark is opioid dependent. We have him in counseling. We have him over at Syracuse Behavioral Health. But it's very important that everybody that opens that chart sees that and that we don't start Mark down a cycle of abusing opioids again. So we've had some really good success with that. The top 5 utilizing patients, we saw a 60% decrease in their ED visits once we started creating individualized care plans for that group. Teresa Baxter is going to follow me, and she's going to talk to you really a lot more about the addiction issues and the pain task force and some of the things that we're working on in the hospital and resources that are available to you to address these patient populations. Does anybody have any questions for me about the work that we've already done with this group?